Hi everyone, we are here today with the amazing Professor Wendy Brown. Professor Wendy, thank you for joining us.
Thank you for having me.
So we didn't actually plan this, Tash, but the report that Monash are working at doing each year for the Bariatric Surgery Registry, that's the one. It's just been released today. So I thought, what a better time to do a podcast with the lady herself. And I thought we could just discuss the latest report. And maybe if we could start with what the registry is.
So thanks very much, Tash and Damo, for coming and meeting with me again. Just love catching up with you guys and hearing your stories, and I love what you do for the community, helping to support them with their education and understanding what it means to live with obesity and also the treatments that we offer for obesity. So it's just wonderful what you do. So the Bariatric Surgery Registry is essentially a big database. We started back in 2013 to try to track the outcomes of bariatric surgery procedures that are performed in Australia, Aotearoa and New Zealand. And we wanted to see what those outcomes were out to 10 years. Yeah. We wanted to do that because we know obesity is a lifelong disease. It's a disease that people live with for their whole life. And we really believe that any treatment we offer has to be with a long-term view. So it's not good enough to say, well, in 12 months you lost half your body weight. We need to know what's happened at 5 years and 10 years. And we need to know not just about weight loss, but if that's improved people's health, and ultimately we'd also like to know that it's improved their quality of life. And importantly, we need to be sure that these surgeries that are being offered safely, because if they're not being done safely and well, and people are dying because of the surgery or getting really bad outcomes because of the surgery, we need to know so that if we needed to, we could stop doing it. Or more importantly, we learn about who's doing a really great job and what they're doing differently so that we can try to help as many people as we can. So back in 2008, actually, when I was on the board of what was then called the Obesity Surgery Society of Australia and New Zealand, which is now called the Australia and New Zealand Metabolic and Obesity Surgery Society, so ANSMOS. We thought it would be really good if we could track these operations that we were just starting to do large numbers of. It took us a little while to get the money together and to get sort of buy-in, I guess, from different people. But in the end, we were able to start our pilot in 2013. The pilot was very successful, so the government, happily supported us. And we've been going with good numbers now, probably since about 2016, because it took a little while to roll out.
Yeah.
It's an extraordinary registry in that it's not compulsory. We very much rely on our patients to gift us their data.
Yes.
And we rely on surgeons and their teams to help us collect the data. This year we managed to collect data on just over 19,000 patients.
That's amazing.
Wow.
Which was just over 80% of the procedures done in Australia and New Zealand, we think.
Amazing.
And of those procedures, about 3,000 of them, sorry, that's the Australian figures, I should have said. So just on 19,000, so it's about 83% of the procedures that occurred in Australia.
Yeah.
And about 17,000 or thereabouts were the first time the people had had a procedure.
Okay.
And then about 3,000 were sort of what we call revisional, which are kind of fix-up procedures. So, sometimes because people have got reflux or because the people aren't losing as much weight anymore as they used to, then we have to go back and either change over to a different procedure or do a sort of correction on the surgery. And the strength of the registry now is that we are actually able to start to tell a good story about what's happening to different people who've undergone different procedures. In terms of weight loss, we see that there's excellent weight loss with all of the procedures out at 5 years. The best is probably the bypass procedures, followed by the sleeves and then the band. But in real terms, we're only talking 5 to 8 kilograms difference between each of those procedures. And it's
Wow.
really important that we know out at 5 years we're sustaining that weight loss. We're also seeing excellent improvement in diabetes. So the way we track health is by checking what's happening to people's need for diabetes treatment. And we know that around 70% of people at 1 year after their bariatric surgery don't need any other treatment other than bariatric surgery for their diabetes.
That's incredible.
And people who are on insulin, nearly all but 20%, so about 80% of them come off their insulin, which is huge because insulin is such a difficult drug to be on. And then in terms, and we're now able to track those things out there. And we're starting to also understand that for some procedures like sleeve gastrectomy, your highest risk of needing a second operation was within the first 12 months. And that's probably because of complications of the surgery. And then after that, there's very small risk of needing another operation. With the bypasses, it's probably similar, but with the gastric bands, which is a procedure we're not doing as many of anymore, they're very, very safe in the early. There's not very many reoperations early on, but out at 5 years, we're starting to see more and more reoperations as people change to different procedures. The exciting thing for us this year is that we'll be able to add in, for the first time, patient-reported outcomes, which really starts to speak to the patient experience, because you can lose 100 kilos, but if you're vomiting every day and you can't go out because you can't eat anything, then it's probably not a great success. So, but on paper it looks like, 100 kilos, amazing, So we're so excited. Alyssa's piloting these at the moment. We're doing our very first SMS direct patient project at the moment. We're selected groups of patients. We're SMSing them so that we not just get the follow-up data from their surgeons in their rooms and from our call centre, but patients will have the option to give us their, gift us their data directly, which is really incredible. And when we can start to collect those information about how people feel after the operations, I think we'll really start to round this data set out. And again, this year we just showed that the surgery is so safe. It's about as safe as having a gallbladder operation.
That's amazing.
So it's really high quality in both our countries. We're very fortunate to work with really gifted, I think really working within a really good healthcare system that supports our patients. And we have great surgeons, but not only do we have great surgeons, we now have really great teams of healthcare professionals that work with the surgeons just to make sure that the patients get what they need.
Amazing.
So, it just worked out so well that today happened to be the day we were launching the next report.
Yeah,
we just happened to have this interview.
I was so excited yesterday when I got an email from some of your team and they said that it was going to be released today, and I was like, this is perfect. So
timing. I'm incredibly grateful to you and to the team for wanting to report patient outcomes directly from patients. I just think that's very unique, and it's very important for patients to feel heard.
And look, we know not everyone wants to be involved in the registry. About 3% of people decline to be part of it. And that's well within their rights. I guess people worry about data being breached and things. We do store everything here with the same level of security as they do in banks. So, we're as sure as we can be that the data's safe, but obviously even banks get hacked these days. But, just to reassure people, the data we keep is very lean and we don't have really sensitive financial or anything like that. But if we can get that patient voice coming through, it's just going to make this data set this opportunities that come from this data we're collecting so much better. And to try to support that, we're really working hard at the moment to get a proper consumer advisory group. So the registry is overseen by what we call a steering committee. The chairman of that is Professor Ian Paterson, who's at the University of Sydney, and he has devoted his life to diabetes and obesity research and clinical practice. He's just a wonderful man, and he's not a surgeon, but he's very interested in weight loss and the impact, and just being really clear and accurate about what that role of bariatric surgery is in the journey of someone with obesity who chooses to have this as a treatment. And then we've got representatives from that professional organisation, Aaron Smoss. Then we've got representatives from another independent surgery group that just operate on the stomach but don't do bariatric surgery, because that gives a little bit of independent lens. We've
Yep.
got representation from the College of Surgeons, and we've got people with lived experience as well as people who are just consumers, not just, but who are consumers from the community that are advocates, I guess,
Yeah.
to help put forward the consumer voice. So we've got 3 or 4 consumer advocates now on our steering committee, but that's only 3 or 4 people, and we want to expand that to have a proper consumer committee that'll be chaired by the consumers on our steering committee. And we really want that committee to help guide the future of the registry, because we've gotten the registry this far. We're starting to get really good numbers coming through. We're going to have this amazing resource, and we need to understand what's important to consumers to help guide the way we look at the data, to start thinking about how we can use the registry to conduct trials to improve what we're doing. And also how we can start to use the registry to produce guidelines for surgeons and for their teams. And we've talked about this before. So that there's a bit of a, and you love a recipe, but a bit of a recipe to help people that have had this life-changing operation but just need extra support. So we can have guidelines on how to do the surgery safely, how to do the surgery optimally, but also how we should best support people into that post-operative period. We're already using the data for registries. We work with a group called the WIN Network, the Weight Issues Network, and they've helped us design little one-pagers that will be going out to all the doctors who participate in the registry so that they can give those to consumers who are thinking about having surgery. And even for those who've had surgery, so they can understand what the latest is on expected weight loss, what the risks of surgery might be, and just help with that sort of education. There's so much more we could be doing. We need that consumer group to guide us. So, I think we'll probably be reaching out to you guys soon. Hopefully you guys will be involved. Hopefully you'll be happy to put it in on your group. If there's people who would like to be involved, we'll do an expression of interest so that we can pull together a group that become our consumer steering group, I guess. Which again will just really change what we're able to achieve, I think, and help us focus on what's important to our patients. Because ultimately there's not much point in doing this if we're not helping people.
Do you find that for the patients it can be a lot easier for them to give the feedback when it's more in a survey, sort of, not directly to their surgeon? Sometimes I think we can get a bit intimidated by, the surgeon sitting there asking questions. So do you find that sort of style works?
Yeah, definitely. We know that when we go direct to consumers or direct to patients, we get, and especially if it's an anonymous survey, we get very honest and raw details. Even when we ring them, and because it's a natural instinct to, I guess, want to please your surgical team, your treating team, because you want to be a success, you want to show people, and so you don't want to talk about the things that aren't so good sometimes. So having that sort of being able to keep it a little bit separate, I think, is really important. We're trying to publish a paper at the moment, and one of the criticisms was that we get too much directly from the patient, and I've had to write back and say that I think, we need unfiltered information. Like we said, around a survey, you helped us when we're trying to work out, should we be looking at blood clot prevention after bariatric surgery, and should we be trying to use the registry to help us understand better, what sort of prevention we should be giving people to stop them getting blood clots around the time of surgery. And, you probably know people often get little injections under the skin, or there can be tablets you take. And it was really eye-opening, because some of the things we thought consumers would really want, like there's a tablet you could take instead of having an injection, but the downside to it is you can't reverse it quick. And so if you started to bleed, there's, maybe a 50% chance your risk of bleeding goes up, and it's still a very low risk. But we heard loud and clear from consumers they would not accept any increased risk of bleeding, and they'd rather have an injection. And that's totally opposite to what I predicted. I just thought, people who want to avoid having an injection, they'd much rather have a tablet. So
it's interesting, isn't it?
If we don't ask, we don't find. Within a day,
I would definitely be the person that would rather an injection.
And I think within one day, 60 of your members got back to us was
Wow.
incredible. It was the best
Yep.
response we've ever had
Oh,
to a survey.
Thank you, BSA. Thank
Yeah.
you.
Amazing.
I'm very grateful. It's very valuable because I think too often as doctors we see problems and we see questions, but if we're asking the wrong question because we're thinking about it from our perspective, then we're not actually doing our job properly.
Mm.
So it's great to have
Yeah.
that opportunity. So thank you for facilitating.
Oh, most welcome.
But it's great for us to have the opportunity as well to speak to these things because, you know, for a long time, I was certainly raised with, you know, we didn't question our doctors and all this sort of stuff. And quite often I'd walk away from an appointment feeling like I hadn't been heard because I sort of hadn't had a chance to even speak.
Yeah.
And, you know, that's really turning. And I think it's wonderful that, you know, we can partner with you know, the likes of Monash to really get these messages out there.
Yeah.
Yeah, I agree. I mean, when I was a junior doctor, we used to do ward rounds and we, you know, especially in the country, I think, you know, you go in to tell people about these big operations they're going to have. And they go, it's all right, doctor, I don't want to know anything about it. Just do it. And you go, yeah, but I sort of have to tell you about it. No, don't want to know. And I think now patients do have an expectation that they're a partner in their own healthcare.
Yeah.
I don't think it's unreasonable. And, you know, they're fortunate to, I guess these days, well, it's a bit of a catch-22, I suppose, that there's so much information out there. That can be overwhelming too. So if you Google something, often the people who are involved, you know, when there's things on the internet, they're often people who feel strongly one way or the other that are putting things up. So I still think you need that good relationship with your treating team, the doctor, the nurses, everyone, so that you can say, well, I read this on the internet. Do you think this is going to happen to me? Or is this something that pertains to my surgery? Or is this something that's done commonly? Or is this just some random thing that, you know, someone's put on YouTube? Like doctors love, you know, surgeons love our new techniques. You know, we do these new things from time to time and someone will post things on YouTube and suddenly everyone's like, oh, is this what we should be doing? And it's like, and it can be very, very overwhelming and confusing. So increasingly, I feel like a lot of my role is to become an interpreter for my patients to try to help them filter what we currently understand of what's right and wrong, appreciating that what we think is right today might be proven to be wrong tomorrow. And again, that's where the registry is really important because now we can look back and say, well, this is good about that and that's bad about that. And we might modify our practice accordingly.
Yeah, 100%. I actually wrote a post today on Bariatric Support Australia that was very much along those lines. Just from my own perspective, I run things like information, the new information, through a series of filters, and it goes through, if it's to do with the nutritional thing, it goes through what I know to be true and what my dietitian has told me, and it gets filtered that way. I don't just blindly believe whatever it might be. The same would go with any procedures, or if I was to start a new exercise plan. You know, we should certainly filter things back through our medical professionals because that is the safest way, I believe, for us to navigate our health journey.
That's what we're there for. I mean, I've trained, you know, I did a 6-year undergraduate program, I did a 3-year PhD, I did 10 years of surgical training, and I've been a surgeon for 20 years. You can't expect someone who's, you know, made a huge decision to have an operation that, you know, is going to have an amazing impact on their life, but you can't expect them just to understand it. Something that's taken me 30 years to understand.
Right. That's exactly right.
And I still think I'm learning.
That's why it's so important that we do have that good relationship, and that's what can be fostered by being involved with the registry, and we can provide our data and we can feel like we're contributing, which is really exciting.
I think that's something that we see a lot is people in the support groups will say, yeah, I'm 6 weeks post-op. I didn't know that, and we as much as we like to encourage people that, this isn't just about weight loss, it's about the whole journey. I think a lot of us, we still have these expectations that, I should be losing 10 kilos a week after I have weight loss surgery. And, and then they hit the 6-week mark and none of that has happened. And it's like, oh my gosh, I've failed my sleeve. That's a term that we hear a lot. And it's like, you haven't even started yet. You're still healing. And
there's a whole journey.
There's a whole journey, and there's so much information. And I think that's what I love about what we're doing is we're sort of showing people how to access it.
Yeah, and it's fantastic. And look, we overwhelm people with a lot of information. When they come in, they might see the surgeon, they see the nurse, they see the dietitian, they come back for another appointment, they have tests, and we go through things over and over again. But I often think, and I might have said this to you last time, it's a bit like when you go overseas, you read the Lonely Planet guide.
Yes.
If you're from my age group, but these days you probably Google the place and you read it and you sort of think, oh yeah, sort of makes sense. That's sort of how you get from the Louvre to the Eiffel Tower or whatever. But it's not until you get there that you really understand it.
That's right.
Yeah.
And you read the Lonely Planet guide again, or you read those travel guides that you've read before you leave, and they suddenly make a lot more sense.
Yep.
So we all learn repeatedly. I'm trying to learn golf. I'm shocking. Like, I am the worst golfer in the world. But I have to keep reminding myself I didn't learn to do surgery in 6 lessons.
Yep.
It has been 30 years of learning my craft. And I feel like people who have a life-changing procedure like a bariatric procedure, that it's a bit of a lifelong journey too.
It is.
It's learning, it's refining. And that's, again, we're sharing your experiences through BSA, but also through the registry and through other opportunities. And I know Damo's gifting us his time to speak at an international congress of all surgeons from all over the world. I think we've got 1,400 surgeons coming from all over the world to Melbourne. But it's so important that people keep sharing with us so that we can continue to improve. It's that symbiotic relationship, I guess.
That's right.
Yeah. It's just amazing what is happening. When we started BSA, Tash said to me, well, I'll only do it if we can, make a difference. And at the time, you sort of, you don't,
you hope you will.
You hope you will, but you never really see exactly what could happen, and now it's just like the possibilities are incredible, but being able to bring the surgeons and the dietitians and psychologists, exercise physiologists, and the consumers all together so that people feel like they're on that level playing field with everyone. It's really special.
Yeah, it's really amazing what we're very grateful, to you both.
Oh, we're grateful. We are the grateful ones.
I just a story, like we've had people that contact us and when we said that we were doing a podcast with you, people contact us, say, Professor Wendy's amazing. She did my surgery, or she's been seeing me every single day that I've been in hospital with whatever has been going on, and we sit there going,
yes, we believe.
Yeah, we believe that. And there are so many surgeons that are like that we're hearing these amazing positive comments about.
Yeah.
And I just love seeing the change that is happening.
There definitely has been a swing over the last 5 years.
Oh, that's wonderful.
It really is.
It's really good to hear.
Yeah, it's very exciting. It really is exciting, the changes that we're seeing. I think that people are stepping up as well, in terms of their own understanding. Yeah. I think that like you said, I think that they do have more of an expectation to be involved.
And I think it's important that they don't feel like those patients I saw back when I was a junior doctor where they felt, or they didn't want to know, or they didn't feel they could ask.
Yeah.
I think we want to empower people. This whole weight loss journey is about empowerment. It's about empowering people to live their best life.
Yes.
And look, if you don't want to go on a weight loss journey, that's fine too. You know,
Mm.
but if this is a choice you've made, then you're doing it usually because something's driving, you know,
Yeah.
it could be a health issue, it could be a quality of life issue. I always ask my patients, why are you looking at doing this? And it's always because I want to be able to run around after my kids or my grandkids.
Yeah.
I want to be able to, you know, fit into the sort of clothes that I want to wear. I mean, these are all really good reasons. I want to, you know, basically I just want to live my best life,
Yeah.
is what people are saying.
That's right.
And, you know, and I want to improve my health. People are really, if they've got health issues, they want to resolve them. And for some younger people, they can see moving forward that if they don't lose weight, that they're going to get health issues, and so they want to avoid them. But it's all about, you know, making the most of the opportunity, and people shouldn't be afraid to ask to be part of those decisions and to be active participants. And the level of participation you have is really up to you, you know.
That's right. Yeah.
And there's some things that, you know, sometimes when things go wrong, you kind of just have to trust us that we know, you know,
That's
this
right.
is probably the best way to fix it. Might not fix it the first time, we might have to go again a second time. But main thing is we keep trying and working on it together and keep each other posted on the journey.
Yeah.
Yeah.
And that's where that communication is so important with our surgeons and, you know, our whole team, really, so that, you know, if we're worrying about something or, you know, we feel like something's going wrong, we need to be able to reach out and say, hey, this is what's going on, and let our teams make a decision in you know, what's happening with us, instead of going, oh, I'm probably just overreacting and, you know, I won't say anything because I feel silly. Or, you know.
There's no such thing as a silly question.
Yeah.
That's right.
Ultimately, you know, again, and I think that's why it's really great that these groups like BSA, it gives people permission to ask questions and not feel like they're being silly.
Yeah.
That's right.
And if they run something by the group and say, is it normal at 6 weeks that I haven't lost 50 kilos? You know, have I failed my sleep? You can all, you know, shout back.
Yeah, everybody's
no,
like, no,
Yeah.
it's normal.
you're fine.
Yeah. And we always know that the first couple of comments are going to be, it's normal, trust the process. Yeah. It's not like, oh yeah, you stuffed it. You know, there aren't those sorts of comments. And I think it's really nice to be able to put our concerns out there, and other people are going, you know what, I had the same thing and this is what I did. And, you know, it just makes you feel like you're not alone.
Yeah, very much so. So, Professor Wendy, how should people, like, for our consumers, for our members, for somebody that maybe is looking up bariatric surgery and they stumble across the registry, how should they make the most, or how should they look at that data, and what should they take from it? Because a lot of people, the first thing that I know they do when they open the registry is they go to the complications and they look at those and they go, oh my gosh.
Yeah, it can be a bit overwhelming.
What does that mean? Rather than, I mean, I don't know, maybe it's a human nature thing. I'm a bit like that too. I will kind of like go to what's the worst possible thing that could happen? Okay, and then we work our way backwards.
Yeah. And look, I think everyone approaches these things in the way that suits them and what they need to know. But if you go to the complications first, the worst thing that could happen, you could die.
Yep.
And there's been very, very few deaths in the registry. And, you know, whilst we put numbers in there, and I think there's been 62 deaths or something we've captured over the last 12 years, that's 0.01%.
Yeah.
So
that's incredible.
let's
really
phrase it the other way, 99.9% chance you're not going to die.
Yeah.
Yep.
Which is great.
Yeah, awesome.
And the risk of having a major complication is around 3% for your first operation. It's a little bit higher for the fix-up operations. It's probably about 7% for some of them. But still, rephrase that, 95 to 98% chance that you're not going to have
that everything's going to be great.
That you're going to really do well. Then have a look at the weight loss. And these are all average results. So some people will do better and some people will do worse. But if you have a bypass procedure, you'll lose and keep off, on average, around 28% or 30% of your total body weight. So that means if you're 100 kilos, that's 30 kilos.
Yeah.
If you're if you have a sleeve, it's a tiny bit lower than that. It's more like 25 to 28%. So that's like the 25 to 28 kilograms if you're 100 kilos starting. And then if you have a band, it's more like 20%. So about 20 kilos. So it's a substantial and significant amount of weight. And you can see the curves that, especially with the bypass procedures and the sleeves, you lose a little bit more, then there's a little bit of weight regain after about 18 months, and then it flattens out again. So you should be reassured that those that the weight loss is substantial and it's sustained and it's sustainable at a community level. And I think that's really important, because a lot of what we understand about surgery has come from some really lovely studies from Sweden, where they very closely followed 1,000 patients over sort of 25 years.
Wow.
But also just from single centres where, experts have done the surgery. And so the question is, well, if it's experts that have done the surgery, is that going to apply when it's done, when the surgery is done in the community in a different sort of setting? And we're getting just as good results in the community as these expert centres are announcing.
Wow.
In fact, in some ways, some of our operations are actually doing better. So we should be really reassured that that's achievable wherever you have your surgery, in Australia or Aotearoa or New Zealand. And then I think the other thing to take away is, if you've got diabetes, there's a really good chance that you're not going to need any treatment other than your bariatric surgery, depending on when you had your diabetes, particularly if you had your diagnosis within 3 years. But even if you don't get rid of it completely, it should become easier to manage, which is really exciting, isn't it?
It really is.
And I think it's just really important to read all of this with a lens that it is average. And on the average, there's sort of, people either side. So some people don't do quite as well, and other people do even better. And for those that don't do quite as well, they shouldn't give up, because it just means that there might be other treatments. And so in this day and age, we've got so many different things now that we can look at, like the medications that we could add in, or different options. So that there's a lot of cause to feel positive about it. And I think people should be really reassured if they go to see a surgeon and they've got to sign up in their office saying that they contribute to the registry, because that means that that surgeon and their team are committed to their patients. It means they're committed to reviewing their own results and being really critical about themselves and how they compare to their peers. And they're committed to giving their patients the very best outcomes. So I think when you read the report and you see your surgeon's name there, you should be really proud that you're, you're part of this. I think it's really important. So I think, these reports are very helpful in lots of ways, but there may be bits that you read and you think, I don't think I need to know that. And so also don't feel ashamed or afraid not to read bits that you feel are not going to support you in your journey, because ultimately it's your journey that's the important thing.
100%. So with I guess we've sort of briefly mentioned that there's a lot of talk now with the GLP-1s and all the medications that are available. Do you see that working with the surgeries and surgeons, or sort of either do medications or do surgery? Or
obesity is such a complex disease, and there's lots of reasons people gain weight and struggle to lose it. It's physiological, so it's to do with your genes and with your metabolism that you're born with. And people with obesity, I always say, have just been born with a more efficient machine, and then they don't need as much fuel to keep them going. So if we get a famine, then people living with obesity are the survivors, because they really only need to live on one little bowl of food a day, probably, to survive. So, you can't really change that. That's what you've inherited from your parents. Then it comes down also to psychology, because we all use food for things other than for nourishment. Every single one of us uses it to celebrate, to commiserate, to soothe ourselves, to, but we use food for so many different things other than just nourishment. And that's people living with obesity and people who aren't. And then there's also the psychology of food and some addiction things that probably come in. And then there's the sociology of food just constantly surrounded to us, being marketed to us very effectively, all in an environment where we don't need to expend the energy that our grandparents did even to do the washing. So, it's a really complex set of reasons why people can become obese. And it's also really not that easy to lose it because your body sees fat as a good thing. It's as an energy store. So it fights you all the way. And as soon as you lose weight, it upregulates all the things that make you hungry and it downregulates all the things that make you burn fat. So, you're always fighting. So the more different, ideally we'd prevent it, but we've failed at that. So what do we do so far? Anyway, hopefully we'll get it right one day. But what do we do to help the 30% of people in Australia that are living with obesity that might want a treatment? And I think to just say we have one operation that we can give you all is just a really blunt tool. We couldn't turn every operating suite in Australia into a bariatric operating theatre.
Yep.
Not everyone wants to have surgery. People are scared of it, And then, so now that we have these really effective medications, I think, we need to learn how to use them well. And I think we need to start to treat them the same way as we treating high blood pressure or treating high cholesterol, that it's going to be a treatment that people are going to be on for life, just like the bariatric surgeries for life.
Yeah.
So we need to work that out. We need to work out, do these treatments, should we be putting people on these treatments before they have surgery and see how they go on it, and only reserve surgery for those that don't do well on the treatments or can't tolerate the treatments, because there are side effects that not everyone likes. Do we look at using less invasive surgeries like the gastric band that doesn't give you quite as good weight loss, but it's safer, like the operations are very, very safe and they can be reversed? Do we mix that up with some medication and see if we can combine the therapies and get a similar response to the bypass? For people who've chosen to have bariatric surgery who end up regaining a wee bit of weight, do we step in and do we use the medications to help them lose weight rather than doing the riskier sort of revisional surgery?
Yeah.
So I just think there's so many opportunities, and I think it's really exciting.
And
really, obesity is the only disease, or some people don't like us calling it a disease, but I see it as a disease, but or a disorder. It's the only issue that we don't try to tackle with lots of different treatments. I know we use exercise and psychology and medical, but say you had cancer and you came to see me and I do cancer at the stomach and esophagus, well, you'd be getting chemotherapy, you'd be getting radiotherapy, you'd be getting surgery, you might be getting immunotherapy. There'd be all these other things, as well as the nutrition and the psychology and the exercise. But we would be exhausting every different channel we could medically to try to improve your survival and your quality of life. So why wouldn't we do the same for obesity? And if we've got lots of treatments, why wouldn't we try to find what's the best combo? I think the challenge is going to be the best combo for Damo is not going to be the same as the best combo for Tash, and not going to have the same combo as someone else. So the more we learn about the genetics of obesity and what genes people might have, or the different ways people express different proteins or the different metabolic rates, we'll be able to start to craft another one of our recipes.
Yeah.
So that we work out for people. I think we're a little bit off it, but this is what we call personalised medicine. And I'm really excited that I think we're just on the cusp of that wave. There's going to be 3 or 4 more new treatments come out in the next year or so for obesity that are going to be, very, very powerful. The price will come down. At the moment, they're incredibly expensive. And that's very limiting for a lot of people, unfortunately. But it won't just be these sort of hormonal-based therapies. There's going to be other therapies that will work on the appetite centre. There's going to be other therapies that work on your metabolism.
Wow.
So maybe finally we can start to tackle the multiple reasons why people, become obese. And as I say, prevention's still something we'd love to see. But as we learn more, maybe we'll learn better how to prevent it.
Yeah.
At the moment, all we say is exercise. Eat less and exercise more. Yeah. We all know that's impossible.
I mean, we still hear people say, it's easy to lose weight. It's calories in versus calories out. And it's like, if it was really that easy, we wouldn't have the epidemic that we've got. And this is even coming from people that have, they've had a successful, as far as they're concerned, their weight loss journey, they're hit all their goals, and they're like, oh, well, it's just calories in versus calories out. And it's like,
And if you want to break it right down, I suppose, the only way you lose weight is to expend more energy than you're ingesting. It's just that it's impossible, almost impossible to sustain that into the long term without support or being in a famine. You know, that's really the reality. And, you know, the 3% of people who can keep lots of weight off into the long term, they turn it into their life's business. You know, they exercise vigorously every day, they calorie count every day, restrict themselves to 800 calories a day. They have, you know, a whole focus is around their weight. And you know, who's got time and energy? You know, it's very, you know, it's uncommon to have that kind of resource and facility to do it. And where the treatments help is they just help you maintain that energy deficit into the long term without feeling hungry, without suffering, basically. You know? So the more treatments we have to offer people, I think the better. Yeah. Because we're all cut from different cloths. And look, surgery, the most we've ever done in Australia in a year is probably 28,000. So if you think 32% of the population are living with obesity, I think like our population's like 25 million now. So conservatively, there's kind of 3 or 4 million people maybe living with obesity, and we're operating on less than 1% of them.
Wow.
So there's lots of people that can't access surgery, you know, for various reasons, or who don't want to access surgery. So if they want treatment, you know, it's just exciting that now we have different options.
There'll be other options
that we can offer them.
Yeah, which I think is wonderful.
Yeah.
I really do. I mean, bariatric surgery wouldn't necessarily be a safe option for everybody.
Exactly, yeah. And, you know, people have their own experience with surgery. They have their own feelings about surgery. So it's a considered decision, as I'm sure you know, and I'm sure your community is aware. Nobody should jump into these decisions lightly.
Yes, agreed. Yeah, totally agree.
Yeah, and that's actually something that I've said to people that, you know, if you're sort of on the border of, you know, should I, shouldn't I, and you know, if you sort of could easily be talked out of it, well, maybe it's not right at the moment to go ahead with a surgery, and you know, maybe keep researching it, and yeah, because it's lifelong. It's you know, even when everything's going right, it can still be a really difficult process to go through.
Yeah, absolutely. And you know, a lot of patients in my career, some of them have cancelled the day before surgery, and I just say, well, it's not the right time for you. Then that you've done the right thing. That's right. Then they might come back and see me 3 or 4 years later, and they've put on a little bit more weight, and I should have gone ahead with it. I'm like, no, if your gut's telling you it's not the right thing to do, then this is something you have to be fully sure you want to do, because you've got to put all your energy into it now. You've got to learn to eat differently. You've got to change your lifestyle. You know, it's a whole lifestyle shift. And you've got, if it wasn't the right time for you then, but it is now, then that's the right time to do it.
Yeah, exactly. Yeah, that's right. Totally agree.
Amazing.
Yeah, so it's, you know, the shame is that, so we did see a dip in the numbers in the registry this year for the first, actually there was a dip during COVID, which we expected because it was called Category 3 surgery, so it was thought not to be as urgent as some of, you know, the cancer operations and things. So during, particularly in Victoria where I live, during our lockdowns, we weren't allowed to do them. But there's been a dip this year again, and we think in numbers, and we're not really sure why. It's possibly because of these GLP-1 agonists that people are giving them a go before they have surgery, which is fine. It could be also because it's expensive surgery, and we showed again this year in the registry that less than 5% of surgeries occur in public hospitals. Yeah, it varies by state. You know, Victoria is relatively well served. We've got about 12% in Victoria, but other states it's very, very low numbers that have public access. And so that means people either have to pay for it themselves or they have to pay for it with the help of their private insurance. But either way, there's always big out-of-pocket costs. And during a cost of living crunch, when our interest rates have doubled, where the cost of everything has really gone up hugely, you know, you get the sense that maybe people don't have that sort of money to spend. And I think you're saying, Tash, that people have also dipped into super for other reasons, so super may not be the resource that it used to be for people. And, in 2008, when we had a bit of an economic downturn, we did see a dip in bariatric numbers then. And we saw it also in 2011. So I think it is a bit of a sign of consumer confidence or disposable income.
Mm.
And also, I think when you think there's a sense sometimes you don't want to be away from work if you're worried that your job might be on the line.
That's right.
Because, if you're away for a period of time recovering from a surgery, you can be a bit worried about what that means for your ongoing employment. So I think a lot of those things are playing into it. But most of the reduction was actually in the revisional surgery. So I guess that's part, or the fix-up surgery. So that partly makes me wonder a little bit if the GLP-1 agonists are part of this and people are actually trying to add in medications rather than trying to have a more invasive surgery or more aggressive operation. They're giving the medications a go in the first instance. But I don't know, and that's when we can get these patient-reported outcome measures. It'll be really
amazing
to know, because we can start to unpick some of those issues a little bit more.
Yeah, that's one that I'll be very keen to see in the next report.
So hopefully it'll still be early data because we have to test these things, and Alyssa's doing a great job rolling it out. But it's a very exciting time to be looking at these things. Been a long time developing them, but we've spent, Alyssa's done a lot of community engagement in trying to get this right. So we really hope we can add something.
Yeah, and I'm sure that you will. I cannot wait.
Yeah. Professor Wendy, thank you so much for joining us today.
It's a pleasure. I always worry I talk too much, sorry.
Not at all. This has been fantastic and every bit of what I hoped for. So thank you, and we look forward to our next one.
Look forward to it and enjoying, getting to know you guys, getting to know your community, and thank you to you and to your community for sharing some of our research ideas, for helping us to sort of promulgate the registry. And as I say, we will be putting out expressions of interest for people to get involved. And if people have feedback on the report, there's an email address in the report and on the one pager. We love getting emails. Please write to us, tell us what we could do differently, what we could do better. And if you've got an idea of how we can use these data differently to support our patients, to support our community, we just love that feedback. So
great.
Wonderful. So
we'll include the links in the description as well, so that you can access the latest reports and the emails. So
thank you.
Wonderful. Thanks very much.